Good morning, everyone, and welcome to our third session this morning of the Community Research Academy. We are so delighted that all of you could be with us this morning. Last week we had different speakers, and I hope all of you had an opportunity to answer the questions. Now, the questions aren't a quiz. It's just a way of determining how we're doing in terms of giving out the information for the Community Research Academy. So I thank all of you for participating, and if you have additional questions, feel free to let us know. I know that Larry B. sent me, wanted to talk last week. I didn't have time, but I will call you this week. Today we have Dr. Inmaculada De Melo Martin. And she's a professor of medical ethics in the Division of Medical Ethics at Walcano Medical College. She holds a PhD in philosophy, MS in molecular biology. Her research interests includes bioethics and the philosophy of science. Most of her work has been on ethical and epistemological issues related to genetics, and molecular genetics that I'll have to ask her to explain to me. She has been particularly concerned with calling attention to the importance of science when making ethical judgments, the importance of ethics when evaluating new scientific and technological developments and proposing public policies, and the importance of attending to the social and political context when assessing science and technology. So I now present to all of you Dr. Inmaculada De Melo Martin. Thank you and welcome.
Thank you so much, Lula. Thank you, everybody, and welcome. If it is possible for you to have your video on, that would be great. It's much easier, to have a conversation when we can see people's faces rather than just their names. So if that's possible, that would be great. So I am going to be talking about research ethics today, and in particular, I'm going to be discussing one aspect of research ethics, which is the protection of human subjects. So before I start, does any of you have experience participating in research, in human research? I see some hands up. That's great. So we can discuss some of those experiences. So one of the things that I want to remind everybody before also is I'm happy to have questions, and I will be asking questions throughout, and I'm be very happy if you have any questions or comments as I speak. So rather than waiting, at the last until I finish, it's perfectly okay if you have any questions and you want to have a discussion about it. Again, the topic of discussion is one that raises concerns, so I'm very happy to talk about it as I go along. So let me share my screen with you. I have a few slides. Here, okay, so let me start it. And this, again, as I mentioned, is just a brief introduction to research ethics, and in particular to the protection of human subjects. So before we start with, discussing research ethics, just a brief overview of what is research ethics. So research ethics is an evaluation, of the ethical issues that arise when researchers are doing research. So this is not only questions about how to treat human beings, although again, that's what we are going to be focusing on, but all of these aspects are also aspects that research ethicists also are concerned with. How we design trials, how we use data, whether we protect the privacy and confidentiality of people, Conflicts of interests, something that is more common now than it used to be, given the commercialization of science. Questions about authorship and publication. There is a significant amount of work on research ethics that try to address issues about publication biases, for example. Questions about animal welfare. Before we have any studies, any drugs or interventions done with human beings, we do those studies with animals. So research ethicists are also concerned with how we treat animals. So that's another area. And of course, concerns about how we protect human beings when they participate in research. So as I mentioned, all of these are concerns of research ethics, but I am going to focus just on the issue of human protections. I am, however, happy to discuss any of these other aspects if you have any questions about it, okay? Okay, so let me start with this issue about protecting human subjects. So one of you, Larry, if I may call you so, you mentioned that you have participated in research. So could you tell us what kind of research that was?
God, I've been doing research for 50 years. For instance, I designed a database for utilization review, looking at neonatal intensive care units, 100 hospitals, year worth of discharge data. We had anonymized data, aggregate data, be very, very careful. But while we want to be able to compare one hospital's experience with another, there was never a chance that anybody could work back to any one specific patient.
Right.
When I would lecture on medical ethics, I'd warm up the room by saying, I've been tested for HIV 27 times. These people didn't know what I did on weekends, but the first 3 rows would back off. Then I'd pick up my blood bank ID card, and I would explain to them the fact of the test is an issue, not just the result.
Right.
They were now awake.
Right. Indeed, yes. So anybody else have either participated in research, conducting research, or actually participating as a research subject?
Yes, I have actually. But it's been, I forgot about it actually. I wasn't thinking when you asked initially. I was a member of, they've done these cancer research studies. I'm a cancer survivor. So I participated in that research, but it really was a lot of questionnaires and a lot of in-person interviews.
Right, that's one way in which we gather information. So even if it is not an interventional study, you're not receiving a particular drug or intervention, you participate in research by providing answers to questionnaires. Right, yes. Anybody else? Okay, so let's, these are some images that I am sure many of you might be familiar with. Are images involving human subjects experiments that are now thought unethical experiments with human beings. So you have there an image here of the Nazi experiments, and the majority of people, when they think about human subjects abuses, they think about those experiments. Unfortunately, those are not the only experiments or the worst experiments that have been done with human beings. So in the United States, we have a long history of human subjects abuses. So the one that you have here, this picture, is actually a picture of the Tuskegee study. I'm sure that many of you, or perhaps all of you, have heard of the Tuskegee study, a study that was done by the Health and Human Services. It lasted for about 30 years. It had different phases, but it had significant ethical issues. So from the fact that subjects were not informed about what was happening, to the fact that they were denied access to cures when those cures appeared. Someone raised their hand? Sorry, I thought I had heard someone. to the fact again that all of the subjects were Afro-Americans who actually were from low socioeconomic status and difficulties actually confronting the power of the HSS at that point. So lots of things have been written about Tuskegee and the many problems that that study had. This other picture that you have here is from '63, was a study that was done at the Jewish Chronic Disease Hospital. And in that case, subjects who were, I think there were 22 people with dementia, who were injected with cancer cells to evaluate whether the body would respond appropriately to the cancer cells. The subjects did not consent. They didn't have capacity to consent, and no other legally authorized representative was asked. So this was another, I mean, it's another of the examples, infamous cases of human subjects abuses. And this is actually another long-term study. This was with radiation. Radiation studies, they happened again during the whole Cold War period. Hundreds of thousands of people were experimented upon with radiation experimentation, some of them more serious and with more harmful consequences than others. But also very problematic studies. The idea was to study the effects of radiation so that in case we went into a war, we would be able to help people who were affected by radiation. But again, people didn't consent and they suffer a significant amount of harms. As I said, these are just a few examples. There are many more, unfortunately. So as a result of some of these studies, particularly the Tuskegee study, regulations were passed in the United States to protect human subjects. We have other codes of ethics, the Nuremberg Code, for example, which was the first code to be given to try to protect human subjects participating in research. And the Helsinki Code in 1964 also to try to protect humans when they participated in research. Both of those codes happened at least during part of the timing when the Tuskegee was happening. And certainly the Nuremberg Code was also passed before the '63 that I mentioned, the Jewish Chronic Hospital, and both the Nuremberg Code and the Helsinki Code had been passed before some of the radiation experiments. So we had codes of ethics, to protect human subjects, but people were not following them. So in the United States, in 1974, there was an act of Congress to charge a commission that would study how to conduct research in ways that were ethical and that would respect the rights and welfare of human subjects. So from that, we have actually the recent code of regulations, of federal regulations that are grounded on these ethical principles that were developed by the commission. Is called the Belmont Report. And principles of ethics were provided in that code, in that report, that then were used as the grounds for current federal regulations to protect the rights and welfare of human subjects. So these are the three basic principles that the Belmont Report consider that were necessary to protect human subjects participating in research. So I'm going to point them out and then we can discuss them. So the first one is the respect for autonomy. which requires that we obtain informed consent from people. So in other contexts, there might be other ways to ensure that people's autonomy is respected. But in the context of research, the way in which we do that is by obtaining a free and informed consent. The second principle is beneficence. It's actually a mix of beneficence and non-maleficence. So try to benefit people, minimize harms or risks to people. And the way in which we practice this principle when we do research is by trying to ensure that the benefits of the research outweigh the risks of participation. And the last principle is the principle of justice. And this principle is actually a requirement that we select subjects for participation in fair ways and that we distribute resources in appropriate ways. So all of these principles were actually violated in all of the studies that I mentioned before. As I said, the point of the Belmont report was to develop a code that was used as the grounds for current federal regulations. So as I said, I want to talk about each of these principles, and my concern is actually with attending not just to what these principles mean when we talk about research with human beings, but how we fail to meet them even when we are not violating those principles. So even when we are not abusing human subjects, we are conducting research according to the norms that are established, we are not doing as well as we ought to be doing in the protection of the rights and welfare of human subjects who participate in research. So so how many of you have heard or know a lot about the Tuskegee case? Okay, I see some hands raised. So if you don't mind, can you tell us a little bit about how these principles were actually violated in the Tuskegee case?
Larry here. Basically, none of them. You can't have autonomy if people aren't even informed, so they can't do a consent. There was no beneficence to the people involved, and there's no demonstrated benefit to society. The point was actually made in one of the tapes. What was known about the long-term natural history of the disease was already known, so there's no value add there. Risks and burdens, that's the other way around. They were denied benefit. They were denied treatment. Enough?
Yes, yeah, they were denied treatment. Indeed, there was no benefit to the participants, and there was obviously serious harm by denying treatment, not only to the participants, but actually to family members, because people who were infected obviously could infect their partners. And there was not a fair selection of subjects because all of the subjects were chosen in part because of their lack of power, so that clearly syphilis affected not just Black people, but everybody. And the study was only selecting Black citizens. So that was a way to actually violate the principle of justice. So indeed, all of the principles were violated in the context of the Tuskegee study, which lasted, as I mentioned before, for many, many years, 4 years actually. So someone else had raised their hands. If you do you want to?
Jessica had her hand up, and then we have Mimi after.
Right.
Okay.
Yeah.
Okay, I guess Mimi can go ahead. Maybe.
Okay. My question is, when we talk about this Tuskegee experiment, does it even count as a research study? Is that even, you know, I mean, I understand all of the violations, but what qualifies that as a study?
That's a good question. So originally, the study actually was trying to gather information about the history, the natural history of syphilis. That was the reason for the study. And interestingly enough, there is some evidence that the initial motivation for the study was appropriate. There had been studies about the natural history of the disease with white people. And there were some people who thought maybe we should do also this with Black people so that we can see whether there are any differences in the natural history of the disease. So again, at least according to some of my evidence, it appears that the original motivation for the study was appropriate. How then it was conducted was, you know, highly problematic. But it is a research study, or was a research study, because it was trying to answer a research question: what's the natural history of the disease? It was again, obviously, it had many problems, but that was why it is a research study.
Okay, thank you.
Sure. More questions?
Maybe Jessica might have one soon, but I'll let you know.
Okay. Okay, so let's go then with the, oh yes, we have special safeguards when we recruit vulnerable subjects. So federal regulations consider some subjects, some populations vulnerable, not all populations. So in general, we talk about research subjects as vulnerable, but that's, you know, can be a problem. If everybody is vulnerable, no one is. So we want to make sure that we have a category of vulnerable people because we want to provide particular safeguards for those people. So children, for example, are considered vulnerable. People with mental impairments, cognitive impairments, are also considered vulnerable. So pregnant women are considered vulnerable, prisoners. So there is some groups of people who are thought to be vulnerable. And when we conduct research with those groups, we have to actually meet extra requirements to be able to conduct that research. So as I mentioned, I want to, you know, talk about each of these principles and, you know, what they mean, and then discuss how we fail to actually fulfill those principles. So autonomy is this ability that human beings have to act freely in accordance with our own self-chosen plans. So we think that they're individuals, you know, as agents, moral agents. We believe that there are some ways to lead our lives that are best for us. And we want to choose how to do that in free ways. This is what autonomy involves. We think that respecting people's autonomy is very important for a variety of reasons. You have some of them there. One is that we think that it is very central to a good life. Our ability to conduct our lives according to our own values is very important. And also that when we choose in autonomous ways, we are better able to promote our goals. We tend to, in normal circumstances, we tend to know what's best for us according to our own values, and therefore we are more likely to make choices that allow us to reach our goals of a good life. Now, in political context, for example, we think of autonomy as leaving people alone. So, you know, is how do we allow people to be free? Is just leave people alone. Don't impose constraints on them. However, in the context of research, that's not sufficient to promote autonomy. We need to foster the conditions that enable people to make autonomous decisions. Leaving people alone is not sufficient to promote people's autonomy or to respect people's autonomy in the context of research. So one of the ways in which we try to foster these conditions is by informed consent. What we call a free and informed consent is the way in which we apply this principle of respect for autonomy. Now, as I mentioned, this principle is one that we value significantly, not just in the context of research, but in the political context. And we pay a significant amount of attention to ensuring that people are giving a free and informed consent in the context of research. Though we pay lots of attention, again, we are not very good at providing the conditions, as we will see. But nonetheless, it's one of the principles that we emphasize the most in the context of research. So what does it mean for someone to give a free and informed consent, to participation in research, for example? So people give an informed consent when this happens, when one has the capacity to act or is competent. Capacity and competence are similar concepts, but they focuses on different aspects. Capacity focuses on people's psychology, their ability, the psychological ability. Competence is a legal concept. So, people have to have capacity or be competent to act. In most cases, both capacity and competence go together, but not always. So can you think of a group of people who might have capacity to consent, but is not legally competent to do so?
Children?
Children, correct. So there might be some children, particularly, adolescents, who might have the capacity to give an informed consent. Their psychological ability might be such that they are able to understand the information and provide autonomous decision, but they are not competent. I mean, there are some exceptions, but in normal circumstances, you are not competent until you are 18 when you become an adult. So again, in general, capacity and competence go together, but they are two different concepts. So one has to have capacity, one has to get sufficient information about what is going to happen in the context of research. So, you have to receive information that allows you to make a decision. But receiving information is not sufficient. You also need to understand that information. So often these two things there's a gap between receiving information and understanding that information, and we don't pay sufficient attention to that gap in certain contexts. So we'll see that. So has capacity, receives appropriate information, understands that information, and acts voluntarily, so without constraints from other people. And when this happens, one consents to the intervention or to the participation in research. When that happens, we call this an informed consent, a free and informed consent. If someone refuses, which is a good thing in some contexts, obviously, when one has, again, capacity, information, understands the information, and acts voluntarily, we have an informed refusal. Okay, so informed refusals are good also. One of the things that I always tell researchers when they are doing training for informed consent is that if you have a high-risk study and no one ever refuses to participate, probably something is not being done right, okay? Because it is very rare that in a high-risk study, you would have no one who refuses to participate after being informed, okay? So informed refusals are obviously a good thing. Informed consents, obviously, are also a good thing.
Okay, Larry has a question.
Yes. I can hear you. You have your microphone.
My apologies. Hi. In many ways, this is the area for lawyers. It's all very cut and dried. But in execution, there's an art to it. Language is one constraint. Are you really sure that the person you're speaking to really understand the vocabulary you're using? If they only have a 7th grade education and you talk doctor talk, you've lost them. The other is somebody like my mother-in-law, died in her 90s, legally competent. She was never found by a court of appropriate jurisdiction to be incompetent. She didn't know what day it was, but she was legally able to vote, sign checks, not because she should and the family protected her, but because nobody said she couldn't.
Right, right.
That's an art, not law.
That's correct. That's correct. So actually, when we assess capacity, so as I mentioned before, there are some groups who are thought to be vulnerable when we recruit them for research. People with mental or cognitive impairments are one of those groups. So in that context, researchers are required to assess capacity. So these are adults who are competent in the sense that they have, obviously, they are legally competent to consent, but indeed might lack capacity. So we require that researchers actually assess capacity. Now, assessing capacity is an art, as you just mentioned. It's not an all or nothing thing. So people might have capacity to do certain things, but not to do others. We normally have a sliding scale of capacity. So we would require that someone doesn't need to have a very high bar, to show their capacity if we are just asking for a blood draw, minimal risk. But if we are asking for a high-risk intervention, we would ask that people have to actually show a high degree of evidence that they have capacity to consent. In some cases, people simply don't have capacity. They have particular kinds of mental impairments that, prevents them from having capacity. In that context, we ask that a legally authorized representative actually consents or assents on behalf of the person who is being recruited for research. Again, we have a variety of strategies to ensure that people who have cognitive impairments and lack capacity can still participate in research that might be beneficial. Again, there's some criteria for that, without denying them the possibility of participation in research. More questions?
I don't see
Okay,
any.
yeah.
No, I don't see any questions. No questions.
No questions. Okay. So, so I want to now go with some problems when we try to respect people's autonomies in the context of research. One of them is that we have incredibly long consent documents. So some research obviously have longer documents than others. In the context of research, cancer research actually has some of the longest documents, consent documents. And this is a serious problem when we are trying to promote people's autonomous decisions. So why is this a problem? Why are long consent documents a problem?
Well, I know for me personally, having participated in research studies, that they ask you if you'll participate. In my case, sure, I'll participate. But then they say, okay, to participate, we need you to watch this video. Then we'll come back. We'll ask you some questions. If you have any questions, you can ask. You're adding like a good half an hour, 45 minutes to your appointment. If you have other things to do in your day, who wants to take that kind of time?
Right. Right. So that's yes. So that's the burdens of participation in research. That's something that sometimes is not acknowledged when we think about research participation. But one of the things that we can say is that perhaps that half an hour is burdensome, but it might be necessary for people to know whether they want to participate in a research study that might involve high risk and perhaps little possibility of benefit. So in your case, you know, these were questionnaires. So you might think, listen, it's gonna take me less time to answer the questionnaires than to do the consent process. So just give me the questionnaires. So that, you know, might be a response. But in the context of cancer trials, for example, where we are testing new chemotherapy drugs, it is very important that people know what they are getting into, particularly research trials where, again, there might be little chance of benefiting the individuals who are participating in research. So again, why are lengthy consent documents a problem when we try to get people to understand, you know, to make a decision autonomously?
Okay. Larry has his hand raised.
Right? Sorry about that. A well-known principle in cognitive psychology, the magic number 7 plus or minus 2. People can generally hold 7 things in their head. Some people 9, some people only 5. That's why there are 7 digits in a typical phone number, and then we chunk it with an area code separate. If you give too much information to people, you have, because we know from human cognitive studies what the boundaries are of what they can absorb, we know they've exceeded their capacity.
Right.
And a smart lawyer could use that to attack you.
Right, exactly. So we have lots of evidence that when consent documents are very long, people are not going to read them. So they simply go over the page, you know, going through the pages without actually being able to make any sense. And in some cases, they simply choose not to read the documents because they are just impossibly long. Now, it is very difficult to address this problem. Because we have 2 competing values here. On the one hand, we want to provide all the necessary information for someone to be able to make an autonomous decision. And for that, you need, you know, information about risks, potential benefits, what the study is about, what it entails, all the procedures that you're going to have. And some studies are very complex, so that requires lots of information to be provided. And therefore lots of pages. So that's one value that we have. The other value that we have is giving information to people in ways that they are going to be inclined to read it and to understand it. And sometimes these 2 values actually conflict, like in the case of some research trials that are very complex. And it's very difficult to address these. So some of the ways, Mimi, you mentioned the videos, for example. These are some of the ways in which people are trying to think of other ways to provide this information that might be more appealing to people than reading very long consent documents. The evidence that we have about whether those kinds of strategies work or not is mixed. Some studies have shown that yes, it's better for people to have videos. Others have said that there's not much difference. So we're still not sure whether other strategies might be more helpful. But it's something that it's very challenging. We have to grapple all the time with this problem.
Okay, to add on to the first value, Jessica had said most people will not take the time to read and thoroughly understand the consent forms provided, especially if they are too long or complicated to understand.
Correct. That's exactly the problem. And so, as I mentioned before, in some cases, we don't have much of a choice because not providing some information might be a problem because it might be important information for a decision making. But often, the result is that people are just not getting any information whatsoever because they choose not to read those consent documents. So, a very serious problem. We have lots of studies actually evaluating the length of consent documents. A recent, there was a study that was done I think it was in 2009. The title is Evaluating Consent Documents in Oncology Trials. And the title of that article was something like oncology consent documents, does anybody read these things? The answer was no, they don't. The group actually did then another study about 10 years later, and they actually found that the length of the consent documents for oncology trials had increased significantly since then. So we have even longer consent, which again is not strange given that our research trials are more complex. But we also have, documents that are incomplete or unclear or too complex for people to understand. So in these cases, obviously, we have a problem, not just with the length of the document, but with the content of the information that is provided, and is provided in ways that people actually might not be able to make sense of, which is not a way to promote autonomous decision making. One of the most significant problems that we see is actually this lack of commitment to informed consent as a process. So we not uncommonly, researchers not uncommonly think of consent as an event. An event that happens when you sign the document. This is a legal requirement. You have to have a legal, a signed document in order to have a proof that people have consented to a particular intervention. We can do, there are some exceptions to that, but in general, this is the requirement.
I have one question.
Yeah,
Doctor, from Ms. Scanlon, analogous to online privacy and consent to cookies, etc. Who reads and who understands?
Exactly. So you would think, again, we have lots of evidence that people don't pay much attention to those things. I don't know if anybody knows this, but there was a study that was done actually with those consents in, on the internet when you go and you have to check, either the privacy cookies or whatever. And they did this study where people, to see whether people read the documents or not. And the document, at the end of the document, they had something like, and you consent to give your soul to the devil. So, of course, the overwhelming majority of people checked the consent. So it was a way to show that the majority of people actually don't read those documents. So indeed, this is a serious problem. So, but this issue about thinking of the process of consent as just the checking is also a problem, because we pay attention to just, here's the information, make sure that you understand it. If you have questions, but often it's difficult for people to ask questions when they don't have enough information. So if you know nothing about a topic, it's very hard to ask questions about the topic. So questions that might be of importance. So this lack of commitment is also obviously a problem. So that's for autonomy. So now let's go to beneficence, this beneficence, not maleficence principle, which, as I mentioned before, requires that we don't place people at undue risk, and that those risks are reasonable in relation to the potential benefits of participation. So the way in which we put this into practice is by this assessment of risks and benefits. So how well do we do? So it's, again, this duty to do no harm. In the context of medicine, of course, and much in the context of research, the duty to do no harm cannot be understood literally, because practically everything that we do in medicine involves harm or the potential for harm. So this requirement of the duty, first do no harm, that you have in medicine is actually just a make sure that if there is harm, there is a benefit that actually compensates for that harm or for the risk of harm. So this is the duty to maximize benefits and minimize harms. In the context of research, benefits might not be to the individuals who are participating in the research. This is something that is often misunderstood about the aims of research. Research in most cases is not intended, is not done to benefit the particular individuals who are participating in the research. It is done to answer a research question or to determine the safety, and effectiveness of a drug or an intervention, so that other patients in the future actually can benefit from those studies. Now, of course, if people benefit when they participate in research, that's great, but that's not the goal of research. So benefits can be, maximization of benefits might be either to the participants or to others, and in general is to others. And to minimize harms in this case, particularly to those who are participating in the research. So again, as I mentioned, the way in which we apply this principle is by ensuring that when we do research, that research actually generates important knowledge, leads to improvements for the community, for the health or the well-being of the community. So we don't want to put people at risk if we are not going to obtain any valuable knowledge. So this is one. If you are going to be asking a question that we already know the answer to, then there is no reason to risk people's health or well-being. If you are going to be doing research that no one cares about, then there is no reason to put people at risk. So social value is one of the things that we look at when we evaluate research. The other is scientific validity. We want to make sure that when research is done, it is designed and conducted in ways that will produce, obviously, valuable knowledge. We have, significant amount of problems with both of these issues. Much research is not particularly valuable, and a lot of research is actually lacks validity, scientific validity, for a variety of reasons. And then again, this assessment of the risks and benefits. We require that researchers, when they design the research, actually they minimize risks to subjects who are participating, maximize the benefits to subjects, if that's gonna be the case, and certainly to the community, and that the risks and potential benefits are proportionate. So you don't want to have research where people are running very high risks with the possibility of little benefit either to them or to the community. So in those cases, that research shouldn't be conducted, certainly shouldn't be approved. So some concerns with the application of this principle, as I was mentioning, again, we are not as good as we would like to be. It is very difficult to assess benefits and risks. For many reasons. It's very difficult because individuals have different ways of valuing different things. So what might be risky to me might be just fine to someone else. For example, I always put this example. I have a good friend who does skydiving, which seems to me completely crazy. Very risky, though in fact it is not, compared to other activities, it's not particularly risky, but it seems to me just crazy. So I am, of course, not going to be doing skydiving. So there is not an objective way to see risks and benefits. It depends on how one assesses those risks and those benefits, those potential benefits. So different people, IRBs, researchers, potential research subjects, each can actually assess the same activity in very different ways. And this makes it difficult to have standards that we can share because different people are going to determine what counts as a benefit or as risk, what is safe or safe enough in different ways. So difficult assessment. Often in research, we overstate the potential benefits of that research. We have lots of problems with consent documents in this, for this reason, where people tend to say, to overstate whether people who are participating will benefit from the research. There have been lots of studies evaluating clinical research, for example, for first-in-human trials. So in first-in-human trials, the first trials that are done on an intervention, for an intervention with human beings, the expectation of benefit is just null. And nonetheless, when we try to recruit subjects, we say things like, we hope that you will benefit. Well, that's not very informative for people who have to make a decision about whether that study, whether the risks and potential benefits of that study are appropriate for them. So again, difficult, to present benefits in ways that are appropriate. Now, why do you think that we tend to overstate the benefits of research in consent documents?
Get more buy-in.
Yes, that's the reason. We think that if we present, research as being beneficial, we are more likely to get people recruited for the research. We actually have evidence that that's not the case. So we keep doing it nonetheless, but we have evidence that people can participate in research even if you properly state the lack of benefit or the unlikelihood that you are going to benefit from research. But there is this idea that if we say that you might not benefit, people are not going to participate, which is very interesting, of course, because if we thought that that was the case, that would be a reason to actually say so, because that would be information that would be important for people to make an autonomous decision. If you are hiding information that you think is going to change people's minds, then you're not providing them with information that is necessary for them to make those decisions. So again, that's a problem about the ways in which we present benefits. We also, in relation to benefits, we researchers often fail to emphasize the importance of possible benefits to society as the main reasons for the study. And again, this is important because a significant amount of research is not going to benefit the individuals who are participating in the research directly. It's not going to, the intervention is not going to benefit those subjects. But we hope that we would acquire knowledge that would be important to develop, again, in developing interventions for people in the future. But often we ignore that that's the main reason of research. So any questions about the beneficence? Yeah.
All right. Larry said, my hunch is that the same person who writes the informed consent claim also writes the grant.
Yes. I mean, again, this is one of the issues. We actually, one of the ways in which we are trying for research to be more socially valuable is to get researchers to think about the possible benefits of the research that they conduct. So when they apply for grants, we require, the federal government, for example, requires that they say all of the good things that is, that the research is going to produce. But though that might be okay in the context of getting a grant, then we want to ensure that in the context of getting consent, people are just giving information that is accurate. So, but indeed, that's certainly the case. So the last principle is this: the principle of justice. Often is not just the last in the sense that, it was the last that was mentioned in the Belmont report, but often it is ignored when we assess research and the conduct of research. So again, this principle requires that we distribute the burdens and risks of research in just ways. And the way in which we practice this is by ensuring a fair selection of subjects. So here is the formal principle of justice is that we treat equals equally and unequals unequally. Now, that's, you know, very easy, except that then we have to decide who counts as equal and who counts as unequal. And that's where the difficulties come. In the context of research, the justice that we tend to be concerned with is distributive justice. So in this, again, in the context of research, one of the most important concerns is the allocation of resources, you know, whether we are distributing resources to conduct research in appropriate ways. So one of the concerns that we might have is that we are conducting research that is not producing benefits to society. So that's unjust. Because it creates opportunity costs. If I fund research that is useless, then I am losing the opportunity of funding research that actually may have a significant amount of benefit. So allocation of resources is always involves questions of justice, distributive justice. But also important in the context of research is this distribution of the benefits of research or potential benefits of research and the burdens of that research. How do we ensure that there is a fair distribution of benefits and burdens? So the practical application of this principle, again, is normally by ensuring that we have fair procedures for selections of study subjects. We do so, for example, by requiring that researchers have adequate inclusion and exclusion criteria. And those inclusion and exclusion criteria have to be relevant to the scientific question that is being asked. So we don't want someone, you know, trying to recruit people because they are easier to recruit, because they are closer, you know, some convenience reason. We want the inclusion and exclusion criteria to be those that are actually going to be more likely to answer the scientific question appropriately. We also want to ensure that when researchers select subjects, participants for the research, they minimize, so they select those people who are going to be less likely to be harmed, so we minimize risks, and those people who are more likely to receive potential benefits if those are going to happen in the research. And again, that we distribute the benefits and burdens of research in fair ways. As I mentioned before, in this context also, we are particularly concerned with vulnerable populations, and you have some aspects that might make people vulnerable in the context of conducting research. So people's cognitive capacities, their level of education, their minority status, their economic status, all of these things might make people more vulnerable in the context of conducting research. Again, these factors, except the cognitive capacity, are not factors that are necessary for a population to be thought vulnerable. These are just factors that might make people vulnerable when we are trying to assess the risks and burdens of the research. So some concerns with the application of this principle. As I mentioned before, we often don't pay sufficient attention to issues of justice. You know, we are very concerned with autonomy, even when, again, we are not very good at ensuring that people are providing autonomous decisions. We are also concerned about the risk-benefit balance, so to ensure that we minimize research risks when research is conducted and maximize potential benefits, but not so much concern is given to issues of justice. There are many reasons for that, but a significant one is often IRBs, for example, IRBs are institutional review boards that are charged with ensuring that these principles are met when they evaluate research. IRBs don't have much power over how resources are distributed. So, you know, that's why we often can pay attention to that. IRBs do have power regarding the selection of subjects, and that's where we try to apply the principle of justice. But there are, in the context again of research, some important considerations when we think about justice is whether people who participate in research or the groups to what those people belong are going to have access to the benefits of the research. So not uncommonly, you can have communities participating in research, and then they don't have access to the products of their research, to the medical products of that research. So that's a serious problem. Questions about the share of burdens, whether certain populations are more likely to be burdened by the research, or actually, just on the other side, is whether certain populations are disproportionately excluded from participating in research. This burdens them in the sense that then they don't have access to the benefits. For example, this is a serious problem with pregnant women. Pregnant women are often, for a variety of reasons, it's very difficult to recruit pregnant women and to study, you know, disease problems that affect pregnant women. So often women don't want to participate in research, obviously for obvious reasons, but often researchers simply exclude pregnant women, again, for a variety of reasons. So, but the result of that is that we lack knowledge about how medical interventions affect pregnant women, so that rather than finding that information and putting some women at risk, you know, in the research context, we put all of them at risk because we lack information regarding interventions that women are going to have to take anyway, because, you know, pregnant women get sick and, you know, sick women get pregnant. So we lack information that's actually necessary for to attend to the needs of pregnant women. This is also the case for children, for example. So vulnerable populations that we try to protect, but the consequences of that protection, of trying to protect, you know, the burdens of the participation, is that actually then they suffer the consequences, which is lack of knowledge regarding how interventions might affect them. Questions of justice are also particularly important when we talk about deprived populations. This is particularly important in the context of global research, for example, when we have populations in developing countries where we conduct research, sometimes legitimately so, because they are more affected by particular kinds of diseases. So, you know, it makes sense that we would conduct the research in those countries. But the problem is that we might have fear about whether people are giving a free consent or whether they are participating because they might get some benefits unrelated to the intervention. So medical care, for example, that they might otherwise not have access to. So this is a serious concern when we do research with deprived populations. Again, this doesn't need to be just in the context of global research. This can happen just in the United States when we do research and recruit people from, you know, we incentivize participation in research. One of the fears is that incentivizing research participation with money, which again, we don't often do very much, But the fear is that that would incentivize people who are of lower socioeconomic status, and therefore they are going to be running the risks of the research, but they are unlikely to then get the benefits because they won't be able to afford those, the drugs when they become approved. So again, although in the context of global research, questions of justice are very salient, certainly they are also important in the context of conducting research just around the corner. So I think this is it. Yes.
To add on to that, Jessica said, sadly, some of the vulnerable populations protected here are sometimes exploited in third world countries.
Yes, exactly. So this is, again, this is a serious problem for the research enterprise, because we might have legitimate reasons to conduct research in developing countries. For example, we want to ensure that that there is a diversity of people who are recruited. And, some diseases are more prevalent in developing countries. So we want to ensure, obviously, that attend to those diseases. So that we might have legitimate reasons to conduct the research, but then the problem is, who is responsible? Who has the ethical responsibility to ensure that those populations are actually going to have access to the benefits of the research, if new drugs or interventions are developed? And that's very hard because, researchers obviously don't have the power individually to do that. Sponsors, either pharmaceutical companies or, the federal government, don't have the money to just ensure that everybody's going to have access to the drug or to the intervention. So this is a serious problem that is very difficult to address in the recent context of research. Do we have more questions?
I don't see anything in the chat yet.
Anybody, any comments or, concerns, or some question that you had, something that you were thinking about that I didn't address?
On the last point that you made, and thank you for such an extraordinary presentation.
Thank you.
Enlightened shareholders in major pharmaceutical companies at annual meetings where they oftentimes advocate for different issues, positions, etc., they could, of course, profoundly influence where the skin in the game, much of which the corporation is already using to advance perceived shared interest. They could insist that certain amount of research dollars be dedicated proactively and targeted to other places in the world, even with the anticipated blowback benefit domestically, the law of unintended consequences, that something that is discovered in a remote place of the world might have really profound meaning to the quality of life for everybody in the globe, not only in that one area. So I think there are, strategies and tools available to investors and shareholders to insist and seek to actively influence the direction of research in specific ways, particularly now at this moment in the midst of a pandemic, when the perception is we are all in this together, that might have greater resonance and currency. So thank you for inspiring me to contemplate that point of view.
Thank you, thank you. No, that's absolutely correct. We have a problem with our research enterprise for many reasons. But one of the problems again is what is called the 90-10 problem. Is that 90% of resources in research are dedicated to problems that affect 10% of the global population. So, so this is a concern, has been a concern for a long time. And again, what kinds of strategies can be used to incentivize, particularly pharmaceutical companies, from conducting research that might actually help other populations that are underrepresented in the context of the research that we conduct. And there are some programs that are being developed for that, and certainly the kinds of, for example, with HIV drugs, you know, the global movement requiring drug companies that they make available those drugs to people in developing nations was, you know, a strategy. Of course, hasn't solved the problem, but at least has made, you know, some change. So there are some ways in which, you know, there are attempts to try to address those issues, but they are, you know, global issues, you know, economic issues that affect lots of countries, and it's very difficult to get, in some cases, you know, agreements for all of these things. But indeed, thinking about ways in which we can put pressure, you know, to conduct research in appropriate places for appropriate reasons, you know, that might benefit other populations is a very important activity. Yeah.
Okay, thank you. And Reverend Rivera also wants to thank you, Dr. De Melo, for thorough and comprehensive research. And Jessica also said thank you so much for all the information you provided and your efforts to explain each point. And Larry has his hand up.
As always,
Thank you.
sorry. Yes, I join with my fellow attendees. The layout of the material, the presentation material, slick, solid, comprehensive. Kudos. You're well done. You're done
Thank
good.
you.
Okay. I don't know if the people in the audience would like to play with it, but the challenge with all ethics are not in stating the basic principles, but where things start to interact. You raise the issue of pregnant women. The clear and obvious danger to the pregnant woman, to her child, the clear and obvious benefit to other women down the road who might be sick. You raise that issue. The question is, what kind of rules of thumb, what kind of tools do you apply to make those tough calls?
Right.
That's the fun part.
Right, right. So in the context, you know, I work in reproductive issues. So in the context of pregnant women, you know, we have a bad history of excluding women from many things, but we have a bad history of excluding women from research, or women, not just pregnant women. This is the case, you know, so women are actually underrepresented in research. Minority populations, racial minorities and ethnic minorities are also underrepresented. Again, for you know, historical reasons also. But this is a problem. This is a problem because we lack knowledge about diseases that affect, again, in the context of pregnant women, you know, diseases that affect pregnant women, and particularly we lack knowledge about how the drugs might affect fetuses when women are pregnant. So again, we think that by excluding women from research, we are protecting fetuses, but in fact we are not. We are simply putting many more of them at risk simply because we lack the knowledge. There is a group, actually, in the last maybe 5 or 6 years, there has been a significant push from ethicists to try to develop guidelines for the recruitment of pregnant women to research. So there is some attempts to change federal regulations so that there is more incentive for researchers to recruit pregnant women. Right now, overwhelmingly, if you exclude women for pregnant women from research, you don't have to give much of justification. So one of the issues is that to exclude pregnant women, you have to have very good reasons to do so. And so this might, obviously this would require significant amount of care and attention to the kind of research that is being conducted. But the point is that we think that excluding populations, whomever they might be, and again, in this case, the case of pregnant women, is good for them, but it's not. Because again, we put at risk every other, all women who are pregnant rather than just the ones who are participating in research.
Well, hold on. Again, I 100% agree with your underlying comments. I'm doing some stuff for the All of Us project where we really, really, really are paying attention to broadening the representation of the patient populations. Preach to the converted. Moving on from there. Unless we reread Jeremy Bentham and we start looking at hedonistic calculus and quantify potential risk, because I saw there was a comment in the chat, let me get the quote, foreseeable risk versus unknowable risk. The essence of statistics is to quantify the uncertainties. Is there some mechanism that people are proposing to balance the different stakeholders, the future risks for future moms and babes, the current risks for the subjects under the study? Is there work on this? It's a hard problem for ethicists.
It is a hard problem, but I don't know that again the issue when we recruit subjects for research is to obtain knowledge and potential benefits for future populations, for future patients. It is very rare. In very few cases, we have research that is intended to benefit the participants, okay? Again, that doesn't mean that they don't benefit, but that's not the goal of the research. So these pregnant women are not different in that sense. When we would recruit this is the case with children. We have the same case, the same problem with children. The most common reason for hospitalizations in children is the use of drugs, given, prescribed by doctors off label, because we don't have enough information about those drugs. So, so the issue is, if we conduct research with populations that we want to ensure are protected, we have to provide, design trials and design research in ways that attend to those possible risks, like we do in other contexts of research. But the point of that research is ultimately to benefit, the population. And for some reason, in the context of children and in the context of pregnant women, and particularly in the context of pregnant women, we seem to be wanting to protect them so much that we ignore the fact that we are harming them.
Well, we have the practical problem right now with future vaccines on COVID.
Right.
Where if the touchstone for racial abuse is Tuskegee, the touchstone for me personally in terms of really, really not thinking of the unintended consequences is thalidomide. We're trying to keep people alive from COVID. But what are we going to do if there might be genetic consequences or just high-risk pregnancies?
Yes.
I don't even know how to quantify those risks.
Yes.
But they're the right questions. So we're sure not getting those questions asked now in this administration.
Right. No, certainly not. Now, one of the things is that, many people mention thalidomide when they talk about the risks of recruiting pregnant women. Actually, thalidomide was the result of not doing research.
That was exactly my point.
So, that was an approved drug for other reason that was then thought to be helpful for nausea during pregnancy. Women took it and then, we had the consequences. But that was because we hadn't done the research with pregnant women. So although thalidomide is always used against recruitment of pregnant women, it's actually a reason to recruit pregnant women in research.
With knowledge and insight.
Right.
Pay really close attention.
Right, exactly. And again, the concern about protecting pregnant women and fetuses in particular is one that is shared by everybody. The question is, how do we do that in the best possible way so that we put fewer people at risk, fewer women and fetuses at risk, and we benefit more.
Right. I would also make the point that one area of very little attention is phase 4. Once the stuff is out in production,
Yes.
we don't have
Yes.
great mechanisms to sort of instrument the
Yes.
system to pick up long-term problems. Bariatric research, nobody knew when they did Roux-en-Y that 5% of all those patients come back alcoholic.
Right.
They're changing the plumbing. Things don't absorb properly. They're now having osteoporosis and other issues, but there wasn't a good instrument in place to collect the data ongoing. Once it was released as a procedure, they just went and did it. The surgeons, they cut, they stitch, they're not bleeding, off they go. Surgeons don't see 5 years later what the long-term consequences are.
That's correct. Yes, in fact, again, one might say, you know, that would be at least a reasonable way to collect information for pregnant women and children. Again, this is also a problem with children, you know, to gather information when these drugs are being prescribed by doctors, just to have a system that allows this information to be collected. We don't have it. We don't have in the United States a system that is shared by all states where clinicians can actually provide this information in ways that are reliable. So we don't even have that minimal requirement.
What scares me with COVID, because it's not just a U.S. exposure, it's a worldwide exposure.
Correct.
And at the moment, I believe there are about 7 different well thought of approaches that they've got, but I think there are 150 projects going.
Right.
Keeping track of which ones work long term, who knows?
Yeah, no, that's okay. I mean, you know, diversity in research seems an appropriate thing. You know, I'm a pluralist, so no one knows what might be the best strategy. So, you know, if we can diversify, that might give us more chances of getting the right answer or some right answer. But the problem, yes, the problem is that often we do that without much planning. So we fail to gather necessary information.
Okay, thank you so very much. Your topic was very interesting. The questions were great. Maybe we'll have to have you back for a follow-up one of these days.
I'll be happy.
Thank you so very, very much. And I thank everyone for attending today. If you have any additional questions, write them down and we will give them to Dr. Inmaculada, and I'm sure she will answer.
I am totally, please send them to me and I will address them as best as I can.
Comments from Ms. Scanlon: global problems equals global solutions.
Yes, I agree. We're not very good at trying to get collaborations with, you know, a variety of countries so that we can offer global solutions. Indeed.
Well said. Thank you so much. And you guys have a great day. I'm looking forward to seeing everyone next week at the same time, same station. Thank you.
Thank you.
Bye-bye.
Bye.
Bye.